Ladies and gentlemen, this is the first session of the monthly AMCANA webinar series. And today we will be going over cirrhosis of liver and its complications with Dr. Abu Herrera. And he will be going over the objectives and his presentation, approximately 30 minutes long. And then after that, we will have a Q&A session. As already described, we will be, this is in a category 1 CME approved activity. I will be sharing a link at the end of this session where you can click and quickly you will have a quick questionnaire about this activity and you can claim your credits. Dr. Abu Herrera, you may continue, please. Thank you.
Thank you, Omar, and thank you, Ghulam Wasfi, for giving me this opportunity to talk on complications of cirrhosis, a very dear topic to my heart. So we're just going to start. So today we're going to go over the objectives of complications of cirrhosis as a result of portal hypertension, including hepatic encephalopathy, ascites, and variceal bleeding. And we would like to understand basic treatment strategies that are around complication of cirrhosis. And most importantly, we will go over the recent AASLD guidelines, management guidelines for each complication and understand how to apply the guidelines in our routine clinical practice. So as we know that prevalence of the cirrhosis both worldwide and US is unfortunately unknown. Compensated cirrhosis, as you all know, can go undetected for many, many years, almost a decade. And when they present with some decompensation, you either see them in the hospital or in your clinic. However, it's estimated that 1% of the population in the US may have histological cirrhosis. So if you look at the cumulative proportion of the patient transitioning from compensated to decompensated cirrhosis, it's actually over the period of 10 years, 50% of the patients will decompensate. And why it's important, we have to ask ourselves why decompensation is important, because if you look at the mean survival for decompensated cirrhosis, it's actually 2 years as compared to compensated cirrhosis, which is 12 years. So when you develop decompensation, then your morbidity and mortality increases, it goes high. So when we talk about decompensated cirrhosis, primarily it's hepatic encephalopathy, ascites, and variceal hemorrhage that we see in our routine practice. My talk is mostly going to be focused on these major decompensation that we see, but there are other possible complications which can make a patient decompensated, which is spontaneous bacterial peritonitis, hepatic hydrothorax, hepatorenal syndrome, portopulmonary hypertension, ACC, and portal vein thrombosis. So what is portal hypertension? Basically, we all have learned in our med school that it's increased due to the architectural changes, increased fibrosis within the liver. It becomes nodular, your liver becomes stiff, and there is resistance to the blood flow. But it's not actually that. It's more than that. It's active vasoconstriction due to decreased formation of nitric oxide, and also there is increased blood flow, splanchno arterial vasodilation, and there is increased blood flow, and hence which increases the portal hypertension. So once you have clinically significant portal hypertension then you develop complications from it, and you see it in the form of shunting, which manifests itself as encephalopathy. You tend to absorb more salt and water, and you develop ascites, which we all have seen, and variceal formation. So this is the picture I always show to the patient when they come to the clinic. I tell them why their spleen is enlarged, what happens, what is cirrhosis, your liver is cirrhotic, basically it's nodular, and I sort of explain all the complication and what to expect in the future, because you never know, like when patient is coming, the first presentation would be just variceal bleed, ascites, or sometimes hepatic encephalopathy. So I just want to go over, explain them that what to expect in the next few years and all. So let's talk about hepatic encephalopathy. So if you look at the hospital discharges from cirrhosis, it has increased. It's actually an old, these are old data, but if you look into the hospital discharges due to cirrhosis, it has increased by 6% just between the year 2009 and 2010. And if you just look at the hospital discharges associated with hepatic encephalopathy, it has increased up to 21% from the year 2009 to 2010. As we are seeing increased prevalence of NAFLD and NASH, so we are seeing more and more complication and prevalence of cirrhosis. So when we talk about complication of cirrhosis, it's most of the time we think about variceal bleeding because it's more dramatic, and when you see as in house staff, and it's that's something that comes to our mind. But actually, if you look into hepatic encephalopathy and if you look at survival at 1 year, actually it's comparable with bleeding varices and hepatic encephalopathy. That sometimes I feel that that's ignored because you see patient is mildly confused. And you just sort of, sometimes it gets ignored. But the point that I want to make here is when you encounter a patient with encephalopathy, either in your clinic or in the hospital, try to think that if this is a transplant candidate and you already know the mean survival is around 2 years. Again, if you look at the odds ratio of 30 days readmission from the complication of liver disease, and if you look at the hepatic encephalopathy, the odds ratio is actually very high, and the other ones are hepatorenal syndrome, and if you see, it's like very, very high odds ratio for the hospital readmission from hepatic encephalopathy, and it's a huge healthcare burden as well. So I'm just going to go over the pathogenesis of mechanism involved in the HE. As we all know, it's increased ammonia production, but it's not only due to increased ammonia production from the gut, but it's pro-inflammatory cytokines and nitric oxide and oxidative stress that stimulates the astrocyte cytokines, and there is a reaction in which ammonia is reduced to glutamine, and it causes astrocyte swelling and increased intracranial pressure and inflammation, and hence we see the hepatic encephalopathy. There is a relatively new idea about leaky gut, and as we all know from the studies on alcoholic patients, that there is increased translocation of the bacteria, and there is increased bacterial byproducts. They go through the portal circulation into the liver and activate a cascades of reaction, which in turn causes inflammation and leads to hepatic encephalopathy. And that's one of the reasons that a lot of antibiotics actually work for hepatic encephalopathy, which we're going to review in our upcoming slides. So grading of hepatic encephalopathy, basically, I always tell the house staff or the working with me that if you see patient with encephalopathy, you should try to grade them. And we use this West Haven criteria. Actually, it's from 0 to 4. 0 and 4 are easy. 0 is like completely asymptomatic patient, and 4 is your patient who is completely comatose. 1 is mild symptoms. Your patient may be euphoric, mildly anxious, and have impaired abilities, lethargy, and grade 2 is disorientation to the time, and grade 3 is basically your patient is somnolent and very confused and may have some bizarre behavior. So this is very important to grade your patient, and it can actually progress. Your patient may present with grade 1, and after a few days may have progressed to like stage 3 or maybe coma. So these are the overt signs, which is like very easily we can pick up if our patient is showing up from 1 to 4, but there is a large proportion of the patient in which they can present with, they have very, very mild symptoms, and it's very hard to pinpoint, and they have overt hepatic encephalopathy, and they constitute the major population if they have hepatic encephalopathy. So precipitating factors for HE, it's basically increased ammonia production, either is from GI hemorrhage, GI bleed, you have excessive dietary protein intake, and you have electrolyte imbalances because most of these patients are on diuretics, so that can trigger an episode of HE. Constipation is another one to consider. And then most important that we should always think about portosystemic shunts. Either you develop spontaneous shunts due to portal hypertension, or it could be iatrogenic when we place tips. Other things to consider is like always go over the medication list. If the patient is on very high dose benzodiazepines, opioids, if they are taking, that's actually going to worsen or cause HE. Infection is the most important thing that you have to look. Even a minor, small infection like UTI or pneumonia can trigger an episode of HE, and you have to look for cancer as well. So most common when they present patient, you have to look for confusion, co-matrixes that you always have to see on the physical exam. Loss of fine motor skill and hyperreflexia, but there is a huge list of less common causes that they can present even with features. So let's talk about role of ammonia in hepatic encephalopathy. You may have seen when patient come to the ER, everybody gets their ammonia level. Is it important? Does it add anything, or it has any role in hepatic encephalopathy? Actually, no, because I always tell the ER physician, what are you gonna do? If you have a patient who is in coma with normal ammonia level, you can admit the patient, right? And if you have very high ammonia level, and if your patient is alert oriented, what you're going to do, you discharge the patient. So looking at this, so increased blood ammonia alone does not add any diagnostic, staging, or prognostic value for the HE patient with chronic liver diseases. A normal value sometime, would need some further diagnostic evaluation. So usually it's not recommended to check ammonia level or daily check it once patient is in the hospital, like just to trend ammonia. The current and the past therapies for the treatment of HE, we have primarily, I'm going to talk about Lactulose and Rifaximin, which are our main state of the treatment. Lactulose, as we know, is a poorly absorbed disaccharide, and Rifaximin, which is a non-absorbed antibiotic, and it reduces the risk of overt hepatic encephalopathy, and it's usually given in an adult patient. Neomycin, metronidazole, vancomycin, they are currently not in use. Neomycin has potential renal and ototoxic side effects, and it's never given anymore. So lactulose, basically the mainstay of therapy currently is for hepatic encephalopathy is lactulose, and about almost 70 to 80% of the patient with acute and chronic HE improve with lactulose treatment. Its mechanism of action is interesting. It's non-absorbable disaccharide that is fermented in the colon. It lowers pH of the colon, and it has a cathartic effect. But actually worse, you have to titrate it for a goal of 2 to 3 soft bowel movements. And main side effect, the problem with lactulose is it's the tolerance. It causes significant abdominal bloating, distension, cramping, and your patient is actually not compliant with that. Rifaximin is minimally absorbed oral antibiotic. It has very broad spectrum activity in vitro against aerobic and anaerobic bacteria. It doesn't have any major drug interaction, and there is no dosing adjustment requirement basically, and it's approved for recurrent hepatic encephalopathy in adult patients. So this is the main trial that was published back in 10 years ago in NEJM, and they compare Rifaximin. It's a randomized controlled trial, and they compare Rifaximin with placebo. And if you look here in the on the arm of Rifaximin, there is a decrease of the proportion of the patient without breakthrough HE was almost 78%. And if you compare with placebo, it's almost 55%. But keep in mind that the placebo and the patient were also on lactulose. And actually this, after this trial, it led to the approval of Rifaximin for the recurrent HE by FDA. So if you look at the guidelines, lactulose is recommended for prevention of recurrent episode of hepatic encephalopathy after the initial episode. Rifaximin is an add-on to the lactulose, is recommended for prevention of recurrent episode of HE after the first episode. Why after first episode? That's how the trial was. These patients was already on on lactulose. And there is no recommendation to use prophylactically lactulose and rifaximin for patient if they are post tips. And that's important board question. Is usually most of the time in the board question, they ask you if you place a tips, and there will be a question asking about the prophylactic treatment with lactulose and rifaximin in such patient to prevent HE, to prevent HE. So under some circumstances and very selected patient, when you have a precipitating factor like a minor infection or GI bleed, and if they have an episode of HE, you can actually stop the prophylactic therapy and see if how your patient would do. You know, sometimes that is in a very selected patient, and as mentioned before, lactulose is very, very hard to tolerate and is sometimes very difficult for the patient to take it. Now we're going to switch gears to ascites. So as we know, cirrhosis is the 8th leading cause of death in the United States, and ascites is by far the most common complication of cirrhosis. 50% of the patient with compensated cirrhosis will develop one of these complications over the next period, over the next 10 years. Ascites is the most common complication of cirrhosis that leads to hospital admission, initial admission. And development of fluid retention in the setting of cirrhosis is an important landmark in the natural history of cirrhosis. And 15% of the patients with ascites would die in 1 year and 45% in the next 5 years. So actually very high mortality when they develop ascites. So once you see patient with ascites, it has a broad, huge list of differential, and most of the time we are asked questions in the board and our USMLE exam that differentiate between the ascites from various causes. So I'm going to focus mostly on portal hypertension, but as a clinician, we should be able to differentiate. And most of this time, what I see in the hospital is a consult for the ascites from heart failure. This is the whole list that you can see. It's not only portal hypertension from cirrhosis that can lead to ascites, but actually there's a huge list. Actually, you can have ascites from acute alcoholic hepatitis. Actually, you don't have cirrhosis, but due to increased congestion and inflammation, acute worsening of portal hypertension, you can develop ascites. Same is for Budd-Chiari syndrome and sinusoidal obstruction syndrome. So let's talk about the workup of ascites. All patients, when you see them with new onset ascites, you should go a paracentesis. That's the first thing that you have to do, diagnostic paracentesis. And initial laboratory testing that is very simple. You have to look for cell count, you have to look for differential, and you have to look for total protein and serum ascites albumin gradient, which we call SAG. And you can order some other specific studies that if you have other clinical suspicion, like MLAs or stuff like that, depending on the patient. But the basic testing that you have to order is just the cell count and SAG and total protein for the first time. So now the treatment options for the management of ascites. First line, you have to ask the patient what is the cause of their cirrhosis or their portal hypertension. Of course, if they are alcoholic and using a lot of alcohol, you have to counsel your patient. If you have Hep C, for example, you have to discuss it. You have to look if they are candidate for the treatment. Sodium restriction and diet education is most important. You have to educate patient, and 2 grams sodium restriction, that's what's recommended if you have patient with ascites. And again, you have to see if you have to start patient on diuretics, and we recommend dual diuretics, urea spironolactone and furosemide, orally with a single daily dose. I usually see patients with on spironolactone 25 milligram 4 times a day. Actually, that doesn't work. What I do in my practice, I consolidate the dosing, the daily dose, especially for the spironolactone, because that's what the dose, that's the dose that your kidney is seeing at one time. You know, if they are 25 milligram 4 times a day, I just consolidate it to 100 milligram once a day, add it with furosemide and see what's the output would be, and increase it accordingly depending on the weight of the patient and electrolytes. Another important thing that I want to mention here is just to discontinue non-steroidal anti-inflammatory. You won't see it on the list of medication, but they take it over the counter. So that's really, really important that you have to ask patient about the NSAIDs. Second line therapies, second line that you have to discuss with patients. Most of these patients are on beta blockers and ACE inhibitors. When they develop decompensated cirrhosis, their blood pressure is usually very low. A good decompensated cirrhosis, their blood pressure runs in 90s and 100s. So you have to bring that discussion. You have to weigh risk and benefits of whether you want to continue beta blocker and these medication. And I usually talk to their cardiologist because nowadays we see a lot of patients with NAFL, NASH, and they have significant cardiac risk factors, and that becomes a challenge. Usually talk to their cardiologist and decide whether it's a good idea to continue beta blocker and their other cardiac medication. As I mentioned, that they are hypotensive, so adding midodrine can be sometimes helpful in your hypotensive patient. Paracentesis evaluation for liver transplant is most important. If you have to select your right patient, and if you think that they are decompensated and they can benefit from transplant and there is no major contraindication, always refer them for the to the transplant center to be considered for the transplant evaluation. And TIPS can be considered, but it's the second line. It's never the first line treatment for the ascites. Portovenous shunt can be placed. I have almost never recommended that, but that's just for the palliative patient who are their survival is minimal, so that can be considered if they have refractory ascites. So management of ascites, what we just discussed, if your patient is showing with 10 ascites, you have to do diagnostic paracentesis. And if it's not 10 ascites, you have to restrict their sodium and add diuretics, okay? So over a period of time, 10% of the patient with what we call it refractory ascites, that you are maxed out on your diuretics and their output is not more, and they have some electrolyte abnormalities, and you can't use more diuretics, then you have to consider the second line therapies. Either you go for repeated large volume paracentesis, depending on if your patient is agreeable with that. TIPS in this condition can be considered if there is no contraindication to TIPS. But keep in mind that TIPS has a lot of, you have to go over the huge list of contraindication, absolute contraindication to TIPS, in which usually it's not placed when you have cardiac dysfunction. If your MELD is more than 18, it has, and if your patient has already hepatic encephalopathy. So these are contraindication to TIPS placement. And again, as I mentioned, like liver transplant is something that you have to consider for these patients. So if you go to the practice guidelines from 2013 for the ascites, the first thing that they have mentioned is to consider diagnostic paracentesis for anyone who is presented with new onset ascites. Routine prophylactic use of FFP and platelets is not recommended. That's something we see all the time, you know, with IR, that your patient is showing up in the ER or in the clinic and you send them for paracentesis, but you are getting pushback from IR that their INR is 2.5 and their platelets like in 40s. But if you look at the guidelines, there is no recommendation to give them FFP and platelets. But it's institutions, it varies from institution to institution and comfort of IR people, I guess. The initial lab work, as we discussed, to check for cell count differential, and you have to look for SAG to differentiate between ascites from portal hypertension versus other causes of ascites, like from heart failure and other causes. First line of treatment of patient with cirrhosis and ascites consists of sodium restriction and 2 grams per day, and you start them on diuretics. So normally on average, the US diet, I tell my patient that average diet contains about 700 to 800 milligrams of sodium. So you have to actually take off all the sprinklers and the added sodium. So you have to a little bit educate. They don't know what is like, how much is 2 grams. They have to look for the labels, and it's really, really important. If they are not paying attention to that, actually, the diuretics won't work. So usually fluid restriction is not necessary in patient with ascites or with cirrhosis unless their sodium is less than 125. And again, you have to discontinue all the unnecessary medication, non-steroidals, and most important, like you'll see all these patients on PPI unnecessarily, and you have to take it off of the list. I just simplify their medications and I go over all the list and make sure that they are not taking anything in which harms are more in continuation of these medication. The risk versus benefits of beta blocker has to be carefully weighed in patients with refractory ascites. Midodrine you can start on patients with refractory ascites. Paracentesis and tips can be considered in those patients with refractory ascites if there's no major contraindication to tips replacement. And then liver transplant is something that you should always consider. Now switching on to our gears to varices. So you can look from this endoscopy pictures that this is the lower esophagus, which is no varices. This is, you can see very small varices here on this picture. And as we go, this is the large, big varices that you can see in distal esophagus. So any cirrhotic patient, they develop varices, and there is 7 to 8% per year chance that they will develop either small, they will progress from no varices to small and large varices depending on their decompensation. So esophageal varices is present in 50% of the patients with cirrhosis, and presence and if we look at the risk of bleeding, it's actually the size of varices that's very important. The bigger varices tend to bleed more, and the presence of these varices actually correlate with the severity of liver disease. If you have child A, equal to 40% of the patient will have varices as compared to 85%, up to 85% in patient with child C. So it occurs yearly at the rate of 5 to 15%. Is esophageal hemorrhage. Most important predicting factor for the hemorrhage is actually the size of varices. And one of the important board questions that's asked that what is the common predictor for the hemorrhage from the varices is actually the size of varices. Other predictors for the hemorrhage are decompensated cirrhosis, your child B and C, cirrhotics, and again, if there is any red marks on the endoscopy, red whale sign or cherry red sign that we see mostly on the endoscopy. There is a mortality of greater than 20% at 6 weeks. Bleeding ceases spontaneously in 40% of the patient when they present with bleeding varices. So important thing about mortality I want to discuss, usually these patients present, they are very sick, they present with melena or most commonly with hematemesis, they are in the ICU, but at the end you control the bleeding, but they die of infection at the end. So it's the infection that you have to always look into these patients. And as I said, like bleeding, it ceases spontaneously in about 40% of the patient, and it's due to like when they lost so much volume, their portal hypertension, portal pressure are already very low, so you can see that. So that's AASLD guidelines that came up in 2017 for the screening for varices, and if you have a cirrhotic patient, then you have to screen for varices. You have to do your first endoscopy, and if there is no varices in that patient, you repeat upper endoscopy in 2 years if there is ongoing injury and is compensated. For example, if you have an alcoholic that's coming up, new cirrhosis will be diagnosed, you do screening endoscopy, and if it's still drinking, you have to do it in 2 years because there is still ongoing insult. As compared to a patient who is with Hep C, you have treated, have achieved SVR, so you can actually repeat your upper endoscopy in 3 years. If they decompensate, then you have to repeat your upper endoscopy in 1 year. And there is no recommendation to put patient on beta blocker if they have no varices. And I see it all the time. When patient comes to the hospital with some decompensation or may not be any decompensation, they have this diagnosis of like nodular liver on ultrasound cirrhosis. When they're discharged, they are automatically placed on a beta blocker. Actually, there is no recommendation to put patient on beta blocker if they have no varices. If you have small varices, you have to consider beta blocker or repeat upper endoscopy 1 year if there is ongoing insult and they are compensated. 2 years if again if it's acquired disease, so you can just consider upper endoscopy in 2 years. For large varices, and what you have to do is start patient on beta blocker, or you can do a band ligation. You do not combine beta blocker with ligation if there is no history of bleeding in the past. If you have patient with child class B and C and you can consider beta blocker or ligation, so you don't combine. And in these patients, I particularly recommend yearly EGDs because these are your sickest patient, they are decompensated. And again, most important board question, again, TIPS is not recommended in such patient if you have large varices. So that's basically to go over the guidelines for the management of someone who is presenting with acute variceal bleeding. You have to place such patient in the ICU because that's your sickest patient presenting with hematemesis or with any signs or symptoms of GI bleed. You have to resuscitate them. Most important thing about resuscitation, you have to be very, very careful about the resuscitation. You are not supposed to over transfuse because a lot of studies have shown actually worse outcomes if you resuscitate them overly. So the goal hemoglobin here is around 7 to 8, and excessive transfusion can sometimes increase portal hypertension and increase the risk of bleeding in such patient. Antibiotics, as I mentioned, cirrhotic patients are very, very at risk of getting infections. You have to start them on antibiotics. You can go wrong with starting them on antibiotics, octreotide, and transfuse with a goal of 7 to 8. Then octreotide is a somatostatin analog, which you have to start. EGD actually can be performed within 12 hours when your patient is relatively stable to stop the bleeding. Sclerotherapy is not hardly done here. TIPS is important here that if you do endoscopic therapy and you fail it, and if there's bleeding after the endoscopy, then I guess the thing to consider is rescue tip if your patient is if it's still bleeding and there is no major contraindication to the TIPS placement. So then that's very, very important that you have to talk to interventional radiology if bleeding is not being stopped, and TIPS is something that you have to consider. Then there's balloon tamponade, and we're going to talk about prevention of rebleeding with combination of, if you have a patient with bleeding, then you have to combine beta blocker with variceal ligation. Briefly, I'm going to go over the risk of bleeding and gastric varices. Gastric varices, as you can see from this, is of different types, but the risk of gastric bleeding is very, very high if you have these fundic varices. And you can see here they have very high risk. Again, the risk for bleeding for them is like if they are of large size, if they have red spot, and if you are very decompensated. So fundic varices is something that can be nightmare. Actually, I just had a patient a few days ago. So management of gastric varices is slightly different than what we do for esophageal varices. And if you have a patient with isolated, if you have with the gastroesophageal varices, you actually, for prevention, you can use beta blocker. If you have a patient with gastric varices along the GE junction, which we call GOV1, you can treat it as I just went over. I just showed you for esophageal varices. So TIPS or BRTO are recommended to prevent first hemorrhage in patients with fundal varices that have not bled. So that's not recommended to place TIPS or BRTO. When they bleed, acute bleeding, you have to go over all resuscitation and all the things that we just discussed. But for varices that you have, especially fundic varices, what you can consider is the glue injection. If you have it in your hospital, that's something we can inject glue. to stop the bleeding. Prevention of the recurrent bleeding, you can again consider beta blocker, and if you have fundic or isolated gastric varices, you can consider TIPS or BRTO. So briefly, I want to go over the TIPS. You can see TIPS is the is placed, and it has its second line for refractory ascites, and it's for rescue bleeding. You can consider TIPS if there is no contraindication in your patient. It actually creates a highway. It connects the portal circulation with hepatic output with hepatic vein, and it decreases the portal hypertension. But most common complication that we see in our clinical practice is worsening hepatic encephalopathy. BRTO, which is balloon occluded retrograde transvenous obliteration. It's actually a catheter that's placed by the IR to the gastrorenal and gastrocable shunt, and then balloon is expanded to block the shunt. So it has its uses for, and it's very interesting. The use of BRTO has been increasing in US for the past few years for these gastric varices, depending on your patient anatomy and if there's no major contraindication. So in summary, I want to go over, I just want to focus that cirrhosis and development of portal hypertension can result in decompensation, and it can manifest itself as hepatic encephalopathy, ascites, and variceal bleeding. Patient with decompensated liver cirrhosis should be treated with the goal to reduce portal pressure, and that's the main thing that you have to, how to reduce the portal pressure, and manage the complication to improve patient comfort and reduce risk of decompensation. Decompensation is the signal for marked increase of risk of morbidity and mortality, and appropriate patients should be referred for the transplant evaluation. Thank you very much, and if you have any question, I'm happy to answer.
Thank you, Dr. Herrera. Thank you so much. And we'll be going to the question and answer session fairly soon. Okay, we will be going to the question and answer session. What I want to share is that please, at the end of this activity, please go to this file that I have just shared with the participants of this activity, where you can, at the bottom, you will have a link where you will claim your CME credit. So that is going to be fairly important. Thank you, Dr. Herrera, for this excellent talk on cirrhosis of the liver and its complications and management. I'm going to be going over a few questions, and we have a question from a participant, and I believe you touched on this topic, that try to avoid people with liver cirrhosis have a lot of other comorbidities possibly as well. And they are possibly on ACE inhibitors, ARBs, as well as beta blockers. And especially when not indicated for the cirrhosis purpose itself, especially for the beta blockers, how do you handle this situation when the patients may be diabetic, may have coronary artery disease? What will be the preference, and what will be the pros and cons of these medication, especially with regards to cirrhosis?
Excellent question, Umar. And as I mentioned before in my talk, that a lot of patients that we are seeing nowadays with decompensation, they have what we call non-alcoholic fatty liver disease and NASH, and they have like significant cardiac risk factors. They are on beta blocker, and when they decompensate, actually their blood pressure is very low. So it's oftentimes it's very hard for them to tolerate beta blockers. And then at that time, I usually talk to the cardiologist and see like if we can decrease the dose of beta blocker or switch to something, especially if patient is on carvedilol, it's going to worsen your ascites because of mechanism of action. Then at that point, I talk to the cardiologist if you can switch it to something else instead of carvedilol. But that's often very, very challenging. You know, you have to look at the patient, and then it's a multidisciplinary approach, and sometimes it's very hard to take them off of beta blocker, looking at their cardiac risk factors.
Got it. Excellent. Next question. I think you answered much of the questions that we had going through this presentation. Concerning management of coagulopathy, any specific aspects of coagulopathy, or it is episode-based, or is it symptom-based management of coagulopathy? I know you mentioned that vitamin K does not have much role However, what could be the potential management of coagulopathy in such patients?
Like, it's a very interesting question. Recently, like, we know that our patient with cirrhosis, they're coagulopathic, but their INR is like 2.33 or even more than that. But often if you see, they develop portal vein thrombosis. So they are at risk of thrombosis, but that's sort of misconception when we see this INR of 3 and 4, and we think that, oh, this patient is at very high bleeding risk. But again, at the same time, they develop complication, portal vein thrombosis, and you see. But to answer your question, there are some recent new drugs, avatrombopag, trombopactins, that you can give, to increase the platelet count. If they are undergoing TIPS procedure, their platelet count is very low in 30,000 and 40,000, and your IR is not comfortable in doing a procedure. So these are the medication. Avatrombopag is something that can be considered.
Okay, excellent. I have another question from Dr. Server. And so it does happen a lot that patients are reluctant to take lactulose.
All the time.
In that situation, I know you mentioned a couple of other options as well. But seeing so many patients that they are not taking for one reason or the other, and especially, let's say, dialysis patients who don't want to take it because when they're on the dialysis machine or they have a commute or anything similar, what is your best um, recommendation for that? And what is the right way to use lactulose enema? Another question.
Okay, so the right way that the lactulose, the problem with lactulose is very, very uncomfortable for the patient and the doctors if you enter into their room, because there's a lot of gas production and they are so distended, there's a lot of cramping, and you start them on lactulose, and with the period of time, they will just stop their lactulose and they won't be compliant with the lactulose. That's a major, major problem. The lactulose, whether you're giving enema or you're giving orally, the goal should be 2 to 3 good bowel movements. You should not be giving it more than 3 bowel movements. And if that is, I always tell patient, just you can dose it daily. If you are having 2 good bowel movements, you're not supposed to take the second dose or third dose. You can just have 1 dose and see if you're having 2 good bowel movements. And that's what we want, even if it's with enema. Enema is very uncomfortable, so if your patient is again in coma, you can place NG tube and give lactulose to that, but enema is something that's very, very hard for the nurses to give, and your nurses won't like it.
All right, excellent. So it's a very fairly important. Yes, please. You were saying?
And another thing, if your patient is not taking lactulose, so again, rifaximin is something that they will always take, and if there is no problem with the insurance, and if that's covered, then you can give rifaximin as in monotherapy if they cannot tolerate lactulose.
All right, excellent. So yeah, it definitely is a lifestyle issue as well for patients. I have another question from SI. I'm not sure who that individual is. However, what is your cutoff for TIPS? And they have seen some gastroenterologists push MELD of up to 18, and some don't go beyond 15.
Yeah.
What is your take on this?
So for TIPS, if you're clearly talking about MELD score, actually the MELD of 18 is relative contraindication, but absolute contraindication is MELD of 23. Nobody would touch that patient or think about placing a TIPS if MELD is more than 23. If it's 18, that's again, you have to see like the indication for TIP placement. Of course, if you're bleeding, you have a bleeding patient and you're putting it in rescue, and you have failed endoscopic therapy, you're a very young patient with no heart dysfunction, I mean, there's no CHF and there's no other contraindication, I would talk with IR and see if their MELD is 18 and if TIPS can be considered in that patient. But yes, if it goes up to 23, it's contraindicated to put TIPS, unfortunately.
Okay, all right. I think one further question for now. So can you briefly go over the transplantation procedure, the basic selection criteria, the process that the patient may take, and eventual outcomes and likelihood of getting a transplant? Just more so as a counseling for people to be able to counsel patients if that is a consideration for them. Can you just briefly go over that as well? Thank you.
Right. So we see such patients all the time, when they come for decompensated cirrhosis with decompensation from ascites, encephalopathy, or they come with bleeding when we see them in the clinic. we should always do MEL score, and if they're MEL sodium, and if it's more than 14, actually that's something that we should refer them to the transplant. Because if you remember, like if they develop decompensation, you know, like their mean survival is 2 years, their MEL is more than 14 over the next few months or year, their MEL will actually is going to go up. So it's better they should be referred at the timely fashion to the transplant center so that they can be evaluated. It's a very rigorous process. It's one of the complicated, it's very intense surgeries, and there are so many things that we look into when we transplant a patient.
All right, excellent. Any further questions for the audience? Any further questions? Okay, I'm just going to go over, I'm going to share my screen, and I'm going to share this document with everybody. This is the approval for the CME activity. And if you scroll down, I have shared this document with everybody who is a participant of this activity. At the bottom, you will have a link where you will click, and you will submit for your CME certificate for this activity. So please do so as soon as possible after the activity. Thank you so much for joining today. This has been, of course, live streamed on Facebook, as well as being recorded. If anybody needs a copy, please do reach out to us. Thank you, everybody, for participating. If there are no further questions, I think we can finish today. Everybody's good. Thank you so much. And thank you everyone for joining. We'll talk to you guys soon. And please be available for the next month's meeting as well. And we will look to schedule that out as well. And we will definitely have a presenter. And Dr. Herrera, please, thank you for your kind presence and detailed discussion on this topic, very pertinent topic. Thank you so much.
Thank you very much. Thank you.